Hello, Bhanu. Happy to see you. Good evening, Palniappan.
Sir, good evening, sir. Dr. Kamlesh, sir. Good evening, sir.
Thank you. Thank you.
Yes, sir.
We are waiting for Dr. Senthil Kumar.
Yes, sir. Yes, sir. He will be joining, sir, shortly.
Yeah. Still 4 minutes to go.
Yes, sir.
How is life?
Fine, sir. Everything going fine. Busy with the hospital, other things, sir.
Classes are going very well.
Yes, sir. Yes, sir. I heard about everything, sir. Fantastic feedback, sir, actually.
Yes, Senthil Kumaran is here.
Yes, sir. Yes, join.
He joined.
Yes, sir. Senthil?
Sir, good evening, sir.
Good evening, sir.
Good evening.
Good evening, sir.
Good e- After 2 minutes, I will call Jyotimay. He should
Yes,
also
sir.
join. Lepan, how is weather that side?
Here also very cold, sir, actually, in Tamil Nadu.
Still cold.
Still cold, yes, sir.
No, we are getting some cold in the night, but in the daytime it is okay.
Oh, now here very cold now itself, 6 or 7 o'clock itself, sir.
Sir, Valiban, sir.
செந்தில் சொல்லுங்க செந்தில்.
Sir, slide share பண்ணிட்டா, sir.
ஷேர் பண்ணி பாருங்க.
Sir, full screen தெரியுதா, sir?
தெரியுது செந்தில்.
Move ஆகுதா, sir?
போதும் செந்தில். ஓகே.
Move ஆகுதா, sir?
மூவ் ஆகுது. எல்லாமே கடகடன்னு மூவ் பண்ணுங்க வேகமா.
Move ஆகுதா, sir?
மூவ் ஆகுது. எவ்வளவு ஸ்லைட் செந்தில்?
Sir, 45 slides, sir.
ஓகே. ஓகே, ஃபைன். சூப்பர் செந்தில். கரெக்டா இருக்கு செந்தில். க்ளோஸ் பண்ணிருங்க. ஸ்லைட் ஷேரிங் முடிச்சிருங்க செந்தில். ரைட். Jyoti is joining us, sir. Sir? Sir is on mute, sir. Kamlesh Tiwari, sir.
Actually, Jyoti was not able to find the link, so I've sent it again.
Oh, okay, sir.
He should join.
Secretary is joining, sir. Aham Vora.
He has taken the class yesterday, so I don't think he will join today.
Okay, sir.
Ajit Kumar, Sivasankaran, and Dr. Akuri Sukhi Prakash.
Good.
Jyotir, good evening, Jyotir.
Yes,
Good evening. Good evening. Hello.
our president has joined now, so I think we should start.
Yes,
Okay.
sir. Yes, sir.
Good evening, friends. This is our third class in a row of
Thank you.
short certificate course, and this
Thank
is the
you.
first class for emergency medicine. It is going to be taken by Senthil Kumaran.
Yes.
Now I will ask my president, Dr.
congratulate-
Paul, to give blessings to all. Dr. Paul, please.
Yes. I congratulate Professor Kamlesh Tiwari, Dean, Indian College of Physicians, and his team for successfully conducting the short certificate courses one after one. Today is the third module on emergency medicine. And emergency medicine now is considered by NMC as a whole subject because the physicians, whatever may be the specialty, cardiology, diabetology, rheumatology, neurology, we have to face the emergencies. And emergency patient, you first come to the physicians only. So it is duty of the physicians to be trained properly regarding the emergency management. So I wish all success of today of such type of module. I am very sure with the able leadership of Professor Kamlesh Tiwari, new feathers will be added in the crown of Indian College of Physicians, and wish you all success. Please proceed. Thank you.
Thank you, sir.
Thank you,
Thank
Jyotir.
Dr. Kumaran, please. Go ahead.
Sir, before that, shall I?
Yeah. Dr. Palniappan is here. So,
Yes, sir.
your blessing, please.
Yes, sir. As a national ICP Vice Dean, today it's a emergency medicine. Today we are going to discuss about the oxygen device and basic airway management by Dr. S. Senthil Kumaran. Actually, after completing my MD in 1999, before doing a MBBS actually in the house surgency, as I don't know about the ABC management, I have lost the patient because of staph injury. So airway has not been properly addressed. So we have lost the patient. So actually, ABC management is very, very important. Nowadays, A, B, C, D, E, F also. Everything in order, coherent order, we have to manage. We should not jump into the C. We have jumped into the C and suturing all the bleeding point. We have missed the post-traumatic staph injury, hemopneumothorax. We have lost a patient. And one famous nephrologist from Tamil Nadu, actually, when he's coming down from the staircase, he's 50 kg weight only. He had fractured ribs and airway has been secured, and they have missed the splenic injury, circulation they have missed. And later on, it has been found to be a splenic injury. So splenic injury, splenectomy done, patient revived. So for the complete physician, ABC, emergency medicine, is a pot and bread and butter for all complete physician. If you know emergency, you can learn as well. You can save a lot of miracles. Within few seconds to minutes, you can lose the patient if you don't secure the airway properly. So that's my message to all the complete physicians and PG students. And here is Senthil Kumaran is a national vice president of the emergency medicine. He's a very good teacher. Lot of practical tips he is going to he is going to teach all the persons who is attending the short certificate course. All the best to Dr. Senthil Kumaran. Thank you very much, our ICP Dean, Dr. Kamlesh Tiwari sir, for the wonderful opportunity. Our friend, Dr. Jyotirmay Paul, National APA President, thank you very much. And thank you very much, sir. Over to you, sir.
Now, Dr. Senthil Kumaran, please go ahead with your talk.
Very good evening to one and all. The first, I thank the ICP, Dr. Kamlesh Tiwari sir, and Dr. Palniappan, my friend. Without his input, this would have not happened. And thank you, sir. And over the next 1 hour, we are going to see about the basic airway management, including the oxygen device. So we are going to see why oxygen device is important and why airway management is important. So if you consider airway is the first part of resuscitation, if you are not taking care of airway, then whatever the resuscitation you do, it will be failed. So Palnipan sir has given a clear example with a stab injury. We are concentrating more on other open injuries. This is called as distracting injuries. So once there is a distracting injury, we should always stick on to our airway breathing and circulation, ABC. So first part of the resuscitation step is A. So we are going into oxygen therapy first. So oxygen, as you well know, it is freely available in the atmosphere, though it has been polluted, but still we are taking the oxygen. The atmospheric concentration of oxygen is around 21%. Okay. So what we are inhaling is 21% of oxygen. What we are exhaling, the gas contain 18% of oxygen. So we are using only hardly 4 to 5% of oxygen is being utilized by our body. So this oxygen should be properly administered. Even in few centers in abroad and as well as in our country, oxygen is considered to be as a drug. So today's objective is what is the need for oxygen? What are the factors affecting the oxygen delivery? And discussion about the flow rates. Delivery devices. What are the devices are available? And pre-oxygenation is how to do a pre-oxygenation. What is called as denitronization. When I entered into my medical school, completing and entering into the internship, at the time, so any patient comes with a difficulty in breathing, we used to use a cannula. Just we will pass the tube inside the nostrils and then the oxygen will be given. Many times the patient died and the relatives used to complain. The patient is giving only a small breath. You obstructed the breath with this cannula. So it is not true. So we need to know what is the device and proper device and what is the flow rate, how to give the flow. And we should know about the oxygen toxicity also. And then we'll go about the basic airway management and what is the sum up takeaway messages. So oxygen, why we need to give oxygen? Whenever the patient is having any atrial hypoxemia or a tissue hypoxia or severe respiratory distress or carbon monoxide poisoning. So if you see these conditions, you have to give oxygenation. So majority of the patients who are coming into the emergency room may require oxygen. They are not able to maintain the saturation in the room air. So the room air, as you well know, it contains only the oxygen concentration of 21%. So we need to give little higher. So based on the need of the patient, we will give the oxygen. At the same time, the oxygen therapy can be titrated with the various devices. In a subsequent slides, we are going to see about all these things. So kindly give oxygen if there is no contraindicated. So where the oxygen is contraindicated, can anybody tell? Any one condition where the oxygen is contraindicated?
Correct. Paraquat poisoning.
Yes.
One person has answered properly.
Excellent. Paraquat is a condition where it is contraindicated. In COPD, it is not contraindicated. So I'll come to the COPD, it is not contraindicated. So COP, we have to give a low flow oxygen. It is not that. Okay.
CHT also it's indicated actually.
It is indicated.
It's indicated, not over guarded O2 mask.
So anything in excess is always a danger. Remember that. We have to give adequate and appropriate dose. Okay. So oxygen delivery factors. Okay. So it depends on the inspired partial pressure of oxygen, alveolar ventilation, pulmonary gas exchange, oxygen carrying capacity of the blood and cardiac output. I'm not going in detail of the physiology of this oxygen carrying capacity, saturation curve, shifting to left, right, and all, I'm not going in detail. I'm just to enlighten you with the practical approach. Okay. So only if you see, I cannot change the cardiac output. I cannot change the oxygen carrying capacity if the patient is having and this hemoglobinemia like methylhemoglobinemia or sulfoxyhemoglobinemia. Until I'm removing the toxin, I cannot manipulate it. Or if the patient is having an abnormal hemoglobin variety, like a fetal hemoglobin or any other variety of hemoglobin, I cannot change the oxygen carrying capacity of the blood. Again, the pulmonary gas exchange, again, it depends upon the ventilation and perfusion quotient. So again, I'm not going to able to change. Alveolar ventilation, again, it depends on the alveoli condition and the lung condition. So only what I can do is I can change the partial pressure of the oxygen of the inspired by changing the fractional inspired oxygen. Why it is important? Just see, this is a patient. Okay, you can see. So the patient is breathing here. Can you able to see the chest movement? So this patient can be given with a low dose of oxygen. Okay, if the patient eats, suppose if the patient is breathing like this, dyspneic, tachypneic. Can you able to see? The patient is having a labored breath. Suppose if the patient is having a labored breath, then the flow has to be adjusted. Otherwise, what we are giving is not going to help. This is a small example, simulated example. So you can. So based on the need of the patient and the requirement of the oxygen, we can select. So there are a lot of devices are there. So broadly, it is divided into low flow oxygen delivery system, high flow oxygen delivery system. So can anyone tell what is a low flow oxygen system? Any example? Any example? So normal nasal prawns or a nasal cannula or your normal Hudson face mask is a low flow oxygen delivery system. What is meant by low flow oxygen delivery system? Nothing but oxygen delivery system is, so it is to give the gas flow that is less than the patient inspired flow rate. That is what we can take is if the patient is breathing at least 30 liter per minute, the minute ventilation is around 30 liters. What the low flow oxygen liter will give you around 20. Okay. So the FiO2 that they receive is from the low flow device. Whereas in a high flow, it is not depend on the patient's flow rate. Even the patient is breathing only 16 times. It will give a fixed amount of 70 to 80% of oxygen. Even if the patient is breathing 30 times, 40 times, it is not flow dependent. Okay. So you can see this is a nasal cannula or nasal prawns. Okay, it is a low flow oxygen delivery system. This is a simple Hudson mask, through which we can give up to 6 liters. We will see how the flow rate and what is the rate you have to set. So the nasal cannula provides up to 40% of oxygen. I have seen in some hospitals where they will put the nasal cannula, they will keep 10 liters, 20 liters. Okay, it is not going to help the patient. It is going to be waste. Okay, so it provides only up to 40% of oxygen. So this can be indicated when the patient is having a very mild respiratory distress. What is the advantage? It is well tolerated by the patient, no claustrophobia or nothing. So here it is again depends on the flow rate and the tidal volume of the patient. So if the patient rapidly breathes, this oxygen will go many cycle. So why I am telling is many small hospitals or a clinic, they will have a separate cylinder. They will not have a central oxygen supply. So when there is no manifold or a central oxygen supply, if they are keeping a cylinder that is containing 18 to 20 liters or a 30 liters cylinder and putting a nasal cannula, calculating 2 liters, it will come over the night. But the patient started breathing very rapidly. This oxygen will be over within 2 to 3 hours. So you need to get ready with the backup, or you need to change the device either to Hudson face mask or partial non-rebreathing or non-rebreathing mask. Okay. So just remember this. This is a flow rate. Okay. 1 liter of oxygen when you are giving. Okay. You know that the room air will contain 21%. When I am giving 1 liter of oxygen per minute, the oxygen concentration will increase up to 24%. If it is 2 liter, it is 28. 3 liters, it is 32. 4 liters, it is 36. So every adding of 1 liter, you are increasing a partial pressure of 4. Okay. This is a small calculation. So up to 5 liters, we can handle this. 40 liters, 40%. If we want to give more than 40% of oxygen, we have to switch over to a simple face mask, or otherwise it is called as Hudson mask. Okay. Again, it is a low flow device. Here the oxygen supply through the tube where the mask will mix with the ambient air. It will be drawn through the side port. Okay. It will be there so that it will enter into the patient. Okay. So here you can see this is an inhalational port. This is how the oxygen comes from the cylinder or from the central supply. Okay. And through this exhalation port, the patient will exhale the carbon dioxide. Okay. So this will, we can give up to 6 to 10 liters. So more than 10 liters, again, it is going to waste. It produces up to 60%. If you want to play less and low, you can use nasal cannula, or if you want to give a little higher, then you can select the mask, face mask. Okay. This is ideally suitable for a patient with a moderate respiratory difficulty. Okay. Then we can able to do this. These are the few high flow oxygen delivery system that are available in the market. Currently, we see a partial rebreather mask that contain a valve. It will not have any valve. Directly, it will be connecting to a reservoir so that the patient takes a breath from the reservoir. Another one is with a valve. It contains 2 valves. Through this, the reservoir, it is a non-rebreather mask. Another one is Venturi mask. Okay, Venturi. We will see one by one how it works. Okay, the partial rebreathing mask. Okay, partial rebreathing mask is nothing but we are giving oxygen will be connected to this source. The oxygen will be collected to this inflated reservoir bag. So once this oxygen is connected here, when you are trying to take a breath, when the patient is trying to take a breath, this will give support with the 100% oxygen. Again, through this exhalation port, some amount of ambient air will get mixed and it will enter into the patient. So this is partial rebreathing mask. So this is a non-rebreathing mask where we have a no valve at all, okay, in the exhalation port, but the patient will have a valve at the reservoir junction. So this is a reservoir. This will be containing around 1 to 1.5 liters of oxygen can be collected here. So through this, it will enter into the supply in the nasal cannula, and this cannula will be connected to the cylinder. So this bag will be filled. So before you are applying this bag has to be filled completely. Otherwise, it will be a problem. So what are the flow rate and how the oxygen concentration changes? So as you well know, with the nasal cannula, up to 40% of oxygen we can give. That is 5 liters. In a face mask, from 6 liters to 10 liters. Face mask can be safely used. If you want to give little higher, more than 10 liters, then you have to use either a partial rebreather or a non-rebreather. So when you are feeling that the patient's oxygen demand is very high, you can always go for a non-rebreathing mask, where it can produce where it can support up to 70 to 90% of oxygen. So it is a very high concentration of oxygen will be delivered to the patient. Okay, it is very good mask and it will be very effective. When I want to give and the cylinder capacity is less, I want to give the oxygen around 10 to 12 liters, then I can use a partial non-rebreathing mask. Okay, through that it can help. Another important thing is Venturi. Okay, this Venturi is gold standard treatment for COPD patient. So fixed amount of oxygen I can deliver. Okay, this is how this works. So this works on a principle called as Bernoulli's principle. The Bernoulli's principle is nothing but when the low flow oxygen is given, it will exert the sideway pressure. By the sideway pressure, it will try to suck the air in the atmosphere, will be entitled into the hole, and then it will go as a high force. Okay, so the patient get enough oxygen. So again, it has a universal color coding. Okay, blue, where we can fix it out 2 to 3 liter. Here, you can see the percentage will be marked and the liter will be marked. So you no need to remember this, but it is a universal thing. Okay, so yellow means it is 8 to 10 liters you have to give and the oxygen will be delivered is 35%. If it is green, it is 12 to 15. Okay, again, it works on the black magic box. So through this, the gas flow will be there. 78, 68, 63, 56, 40, like that it will go. So if you see the peculiarity here, when we are giving a low flow oxygen, that is 2 to 3 liter, then the sucking of the air will be very high and it will be delivered in a low concentration, 24%. Whereas you are giving high flow of oxygen, here the gas flow will be reduced, but the oxygen concentration will be very high. Okay. So it delivers an accurate and constant inspired oxygen concentration. It is universally coded. Okay. It is designed to deliver a fixed predetermined FIO. Even with the nasal cannula or with the non-rebreathing, we can give a range. We cannot say that it is absolutely what we are given, the same thing it is being delivered. We cannot give this because there is lot of dilution will occur. This is the air entrapment port will be there through which the atmospheric air will be inhaled. Okay. So this is a color coding. This is, it comes as a set. It is a disposable, single time. It is not costly. Okay.
Education or in research. So we invite these names.
Can I continue, sir? Okay. So this is a color coded. Okay. Color coded. It contains blue. It is 24% and we have to give 2 liters per minute. 28, it is a 4 liter. 31, it is 6 liters. 35 is 8 liters. 40, you are giving 12 liters. And 60%, we are giving 15. Okay. So this is a fixed amount. So how much amount, just putting this 24 and you are setting with the 5 liters or 10 liters, it is going to be waste. It will take only 2 liters. So this is another magic drug. It is called as HFNC. This is a equipment which saved a lot of COVID patients in the COVID pandemic. Okay, it is a humidified high flow nasal cannula is given and high concentration of oxygen will be delivered. So this will prevent the hypoxia. So once you have applied all these things and the patient is not improving or the patient is, the work of breathing is doing and the patient is not breathing effectively, then you have to start with this resuscitation bag. This is called as AMBU bag. Any idea what is meant by AMBU? I will answer all the questions after this class. Any idea why it is called as AMBU bag? AMBU, A-M-B-U. So many time we will try to expand the acromion. Okay, we are trying to expand the acromion. So yeah, few answers are coming. It is like artificial manual breathing unit, ambulatory manual breathing unit, ambulatory mechanical breathing unit. Actually, all are wrong. Ambu is nothing but it is a trade name. It is a trade name. It doesn't have any acromion. Okay. So it is just a self-inflating bag. It was manufactured by a company called Ambu. Ambu is a brand name. So it doesn't have any explanation for or any acromion there. So when we are using, initially, when we are the patient is, we have to give pre-oxygenate, we can use this ambu bag. Initial ventilation, we will try with this. Or when we are not able to intubate the patient. Please remember the patient die because of hypoxia. They never die because of failed intubation. So even if you are not able to intubate, if you are able to maintain the patient in a normal oxygenation, either by any method, any oxygen devices or any uh, methods like bag and mask ventilation or intubation or using supraglottic airway or even tracheostomy, okay, we can able to do this. Okay. So this is a ambu bag and this is a mask. Okay. These are the two adjuvants. It has been used very well in treating the patient. One is called as oropharyngeal airway. Another one is nasopharyngeal airway. Oropharyngeal airway, we have to put it through the mouth, and nasopharyngeal airway through the nostrils. What is the difference? Why it is being used? As you well know, the first and foremost common obstruction causing the airway is falling back of our tongue. In a comatose patient, the patients will be relaxed. All the muscles will be relaxed. So there will be fallback of tongue will be there. To overcome and prevent that, we can use any one of this airway, either oropharyngeal airway or nasopharyngeal airway. Nasopharyngeal airway is well tolerated. The patient will not have any vomiting sensors because this oropharyngeal airway will produce a gag reflex and try to patient to vomit. And if the patient is tolerating the oropharyngeal airway, it means that the patient need to be intubated to protect the airway rather than just putting a oropharyngeal airway. Okay. So what are the indications for doing a bag mask ventilation? It is called, we can do it as a pre-oxygenation procedure. Before I am intubating the patient, I can give oxygenation and try to do a denitronization, and the entire lung will be filled with oxygenation so that I can take 2 to 3 minutes to intubate. Ideally 30 seconds to 1 minute, we have to put the tube in the trachea and inflate the cuff and connect to the ventilator. If you are feeling little difficulty, that time hypoxia can be prevented if we are giving a pre-oxygenation to the patient or the patient with an oxygen failure or ventilatory failure. Okay, here you have to differentiate between type 1 respiratory failure and type 2 respiratory failure. Type 1 respiratory failure indicates for oxygenation failure and type 2 for ventilatory failure. Or total failure can be there. The patients who are having a snake bite or OPC poisoning or Guillain-Barré syndrome, myasthenia, where the patient will go for a total complete respiratory failure, where we have to intubate this patient. So there are various other techniques are there. I will show you the techniques. Before going that bag and mask ventilation, we need to know whether this will cause a difficulty or not. We have to do a proper assessment. Okay. The simplest way of assessing is Mons. Okay. You have to check for the mask seal. Now it is a fashion that everybody are trying to grow the beard. Okay. When there is a thick beard, the mask cannot be fixed, or any facial trauma or any other situation like a lip laceration or any other condition, endless teeth, where the patient can have difficulty in holding the mask tight. So that will be one of the predictive assess. Obesity. Okay. the face will be very huge. The patient will having a double cheek, or the patient, in case of morbid obese female patient, when you are putting the patient on a supine, the breast will come and compress over the chest, and it will not allow you to lift the chin and go for a ventilation. Or the patient can have a stiff lung or a chest wall. Okay, like the patient is having a severe edematous, or the patient is in a capillary leak syndrome where we are not able to ventilate him. Okay, these are the subtle clues will help you to prepare before the airway accidents happen. There are three sizes are available: adult, child, and infant. Based on the size and the age of the patient, we can select it. In a case of adult, it is containing around 1.5 to 2 liters of oxygen can be, air can be inflated through the self-inflating valve. Okay, this is, we have to hold it tightly. Okay, this is called as C and E type. Okay, it is nothing but remember the English alphabet C. Okay, by with the C shape, you can grasp the mask with your thumb and the index finger. Okay, you can hold the mask. I'll show you the picture. E shape is placing three fingers, that is your third, fourth, and fifth digit in the angle and the rami on the body of the mandible. It should not compress the trachea. Be clear that lot of time when we are teaching the postgraduate, they used to compress the trachea. This will worsen the condition. So just you have to be clear that you are holding only on the mandible and not compressing any other soft tissues or the trachea, because compression can cause a rapid angioneuritic edema there. So this is how the C technique. Okay, this your thumb and the index will capture the mask, and once you are fixing it, you can catch the three fingers. Okay, your third, fourth, and fifth finger. The little finger will be holding on the angle of mandible, and your middle finger in the body and here in the chin. And you have to lift it and try to ventilate it. Here, there are two techniques are there. One is a single-handed technique, another one is double-handed technique. If you have an assistant, okay, 2C and 2E can be done. Okay, how you are seeing here is, it is a 2C and 2E. You can hold it and ask your assistant to bag. So difficult mask, as I already told, the Mons is the important thing. It's just a simple thing. Just like that, within a fraction of a second, we can able to identify if there is any difficulty in the mask seal, or if there is any cause in the causing a problem in holding the mask. Okay, we should plan for the different approach. Obesity, old age, extreme, both extreme age, it is difficult to keep the mask and ventilate the patient. Indolent patient, all teeth will be lost and there is no position to hold it. Okay, just by putting your E here, it will go on compress over this. Any stiffness, not only lung or a chest wall or even the cervical spine stiffness can cause you difficulty in bagging the breast. So in this time, what we can do is we can do a oropharyngeal airway or nasopharyngeal airway. This will prevent the fallback of tongue, and when we are ventilating with the bag and mask, it will help to enter the oxygenation into the lung rather than entering into the stomach. So inserting the oropharyngeal airway does not give you 100% protection from the aspiration. Still, there is a risk of aspiration. So when the patient is tolerating oropharyngeal airway, then it is a time that you have to put a definitive airway and protect the trachea from aspiration. So the very, very important thing is you know the indications, but at the same time, you should know the contraindication. So nasopharyngeal airway should not be used in any patient with a facial injury or base of skull fracture. How do you identify base of skull fracture? Any idea? Two signs are there. Can you tell somebody what are the signs? CSF rhinorrhea. Rhinorrhea will occur later. Yeah, excellent. It's a raccoon's eye. Another one is battle sign. Battle sign is a discoloration where we can see in the mastoid, and raccoon's eyes is a discoloration you can see around the eye. So this is a very important clue. So when you are seeing the raccoon's eye or a battle sign, it is a time that you should not insert the nasopharyngeal airway. Okay. So when you are putting the oropharyngeal airway, you have to select the proper size and properly you have to put it. Okay. So what are the complications can occur? We have seen a lot of complications with OPA. This OPA can induce vomiting. This OPA can, when they are using a smaller size, this can descend down and goes and obstructing over the trachea, or this can cause entering into the esophagus. Like that, we have seen a few cases. So you should be very cautious in selecting the proper size, and once it has been inserted, adequately fix it properly to prevent the further entering into the various other orifices. Okay. And also nasopharyngeal airway will produce epistaxis if you are not properly done. I have seen a patient who have been put with a nasopharyngeal airway. Because of epistaxis, the patient deteriorated and the patient aspirated, and then the patient came to us for just for further management. We intubated the patient with a bronchoscopy clearance, and then the patient gradually improve. This is a small step. If you do properly, it means that the other catastrophic events can be prevented. So how to select the Goodell's airway? So this is the angle of mouth, okay, and this is your angle of mandible. From angle of mouth to angle of mandible, we have to see. There are various sizes. I have just exhibited this. You can see this is again not a universal color code. Okay, this will vary from one company to another company. So there is no classical color coding. So first, when the patient is in supine, you are just doing a mandible opening. Just you are inserting over the hot palate. Then you turn it and then you fix it out. Okay, this is how you have to do it. Whereas in a nasopharyngeal airway, you have to from the lateral edge of the nostril to the torus of ear. Just you can do it, and both you have to be taken care properly, and the nasopharyngeal airway has to be lubricated properly, especially with any xylocaine jelly, so that the patient will not feel any irritation and it will be very smooth to insert. Okay, the insertion is as I showed in the picture. Just do a jelly and then see if there are any deviated nasal septum or enlarged turbinates or any other things are there can cause any obstruction. If nothing is there, give adequate lubrication with the xylocaine or lidocaine jelly, and then you can pass it out. So once this is passed out, you can secure it and you can do a suction, continuous suction can be done. The only contraindication is it should not be used in a facial trauma or the patients with base of the skull fracture. So just I'm showing you, never assume the rate. Always try to count it. Okay, the patient should not anxious. Okay, I'm just showing the see. This is a patient. Patient is breathing. There is no chest rise. Okay, very commonly we see the patients will not have a chest rise. Okay, in a COPD patients. Okay, you can see here the breath sound. You can see the breath sound. See, it is a noisy breath. Okay, it is a noisy breath. So how we can do whether the patient is breathing or not? What we can do is put a patient on a pulse oximeter. Now every individual after this COVID, they are having a pulse oximeter. Through the pulse oximeter, you can measure how much the saturation is there. See, the 94 is there and there is no chest rise. Or you can connect to the capnography. Okay, this can be a side stream capnography or a mainstream capnography. Even the patient is not being intubated, we can able to measure the capnography. This will help you. Okay. Another important concept is pre-oxygenation and denitronization. Okay. As you well know, why denitrization is important in the resuscitation. Denitrization is important, but not in your routine practice. Why? Any idea? Any idea? What is the importance? So by doing a pre-oxygenation, as I already told you, this patient's lung will be filled with 100% oxygen. So we have a safe apneic time. So by intubating, we can take a time. Okay, that is a one point. Another one point, tissue hypoxia. Whenever there is a tissue hypoxia, okay, it will be delayed during the apnea and induction if you give 100% oxygen. Why it should not be done? See, 100% oxygen is good. The lung is getting full of oxygenation. Why should I try to remove oxygenation as early as possible or taper the oxygen as early as possible? Why should not I give 100% oxygen? Any idea why it is? It is not that oxygen toxicity. Okay, oxygen toxicity is not very common in adult patients. Very common in the patients with the pediatric infants. Okay. Any other idea? Intolerant. It is not exactly intolerant. So what is the composition of inhalation, normal inhaling air, what we are inhaling? Oxygen is 21%, 78% is nitrogen, and 1% of which 0.4 to 8% is carbon dioxide and remaining is your inert gas. In an expel air, what is happening? 78% is nitrogen, and 16% to 17% is oxygen, and remaining is your 4% is carbon dioxide, and other remaining is inert gas. So here, if you see carefully, both inhaled air and as well as exhaled air, the nitrogen containing 78% is same. There is no change at all. When we are giving 100% oxygen, this nitrogen will not enter into the alveoli. So the alveoli cannot be maintained open because it is losing its splinting effect of the nitrogen. So the patients, when we are giving more amount of oxygen for a prolonged period, they will go for atelectasis, or otherwise called as absorptive collapse of the lung. So this will happen when we are giving a prolonged oxygenation. So we should not give prolonged oxygenation. It's not exactly flammable. Oxygen is a flammable, but it is not a condition. There are a few situations, special situations will be there where we have to give 100% oxygen, like a restless patient. When we are doing a delayed sequence intubation or an obese patient, their minute ventilation will be very low, or the patients will be having a less minute ventilation because of the obesity. We have to do a head and elevation has to be done. Hypoxia, okay, despite the oxygen therapy. This is very, very common. I used to get a call from the primary physician saying that, sir, I have given 10 liters in the oxygen mask. The patient is not improving. So I started with the patients with the non-rebreathing. 15 liters of oxygen I'm giving. Still the patient is hypoxic. I ruled out all the toxic causes or dyshemoglobinopathy. So what to do? So that time, what we can do is we can start him on NIV, okay, non-invasive ventilation, where high amount of pressures will be there to open up the bronchi and as well as the alveoli. Okay, so there is always chance of desaturation can be there when you are doing a bronchoscopy. So at the time, what we can do is we can give a nasal insufflation. So just by pressing the gun, high amount of oxygen can be done. And all the ventilators, okay, irrevariable of whether it is imported or Indian made, all ventilators now they are coming with 100% oxygen during suction. Okay, suctioning during the suctioning process, just you press 100% oxygen, then you put a suction. It will give 100% oxygenation for 2 minutes, and then it will reduce to the original setting of the oxygen. So oxygen toxicity, somebody has told about oxygen toxicity. Here it is mainly documented in neonates due to the prolonged hyperoxynemia. Okay, so before we used to think that much is better. Okay, bigger is greater, but it is not now. There are a lot of research saying that the hyperoxynemia can lead to retinopathy in the neonates, whereas in the adult it produces ARDS. Okay, this is because of release of free radical oxidation, reactive oxygen content that produces oxygen toxicity. And the same time, if the patient is known case of COPD, they can go for a worsening of CO2 retention because of abolition of hypoxemic drive. So this can be overcome by giving an appropriate, adequate amount of oxygen through a good delivery system. Okay. So ventilation and perfusion mismatch. This very commonly we see in pulmonary embolism or the patient having an obstructive shock. Okay. There we are having a decreased affinity of the hemoglobin to carry. As you well aware that each hemoglobin will carry 4 oxygen molecules. Okay. This whenever there is a affinity is there by it's called as Haldane effect. Okay. So the hemoglobin affinity towards the CO2 will be increasing. Okay. So now I'll give a scenario and you are the treating physician. You just tell me what you are going to do. It's a 55-year-old man found unconscious in the bathroom by the family members. So the patient was immediately taken to the emergency room. On arrival to the ER, his GCS is 7. His vitals were stable, but the oxygen saturation is only 89% in the woman. He is lying flat on the resuscitation bay and making some abnormal breath. How you proceed? Any idea? Any idea? You want to give oxygenate, intubate, secure airway. Okay. Okay. So whenever the patient is having an abnormal breathing sound, it means that patient is having an obstructed airway. Okay, it is an obstructed airway. It may be a stridor, or it may be an angioedema, or it may be a foreign body, whatever else may be. But whenever you are hearing some abnormal breathing sound, it means that the patient is having an obstructed airway. Clear? So how we are going to approach? As an emergency physician, my mantra is only A, B, C, D approach. Okay. So here the patient's airway will be opened. So the history is he was fell down in the bathroom. So there is always a risk of cervical spine injury. So ideally we have to use a jaw thrust to open the airway. Look in whether there is any obstruction is there. If we are able to see it, then we can put a measures forceps to remove the obstruction. Otherwise, you should not do a blind sweep. Okay. Then you can plan for intubation. But before doing intubation, somebody has asked how much time we can give pre-oxygenation. The maximum time of giving pre-oxygenation is not being told, but minimum 5 minutes we have to give pre-oxygenation unless the patient is in cardiac arrest. If the patient is in cardiac arrest, there is no need for giving pre-oxygenation. Just jump and intubate the patient and continue a resuscitation. So this second part, we are going to identify the patients with airway compromise. We are going to use some simple airway maneuvers by which we can improve the oxygen concentration, oxygen saturation for the patient. This is a day-to-day activity. And you need to know what is the best airway adjuvant can be selected appropriately. Okay, we will see. So this is how the cross-sectional of our respiratory tract will look. So the upper respiratory tract will come up to the vocal cord. Okay. Below the vocal cord, it is a lower respiratory tract starts. Though it is not that, only at the level of alveoli we say. But for all practical purpose, above vocal cord is upper airway, or otherwise called as supraglottic airway, or in the below it is a infraglottic airway or a lower respiratory tract. Okay. So when you are putting a scope and you are lifting up, what you see is first is base of the tongue. This is epiglottis. Okay. And this is a vocal cord. This is how it will be looking. Okay. So this is a laryngoscope view for the obturator to see. So this is a trachea where you have to pass your endotracheal tube. The orifice below this is a esophagus. You should not pass. Okay. So you should know the emergency intubation. Okay. Emergency intubation is very, very different than the intubation putting in the operation theater room by the anesthetic colleagues. I'm not underestimating anybody. Okay. So in emergency room, we need to anticipate certain thing. Why? The patient will be in shock. The patient will have a full stomach. In many times, when the RTA comes to the emergency room, they would have been taken a full plate of biryani and one bottle of alcohol, and then they would have done RTA accident, and they would have been coming to the emergency room with a full stomach. Just when you start doing your bag and mask ventilation, there is always few air will escape inside the stomach and will try to push the content outside so the patient can vomit. So this can put the patient on aspiration risk. So this can be prevented, or the patient can be in a profound shock. Okay, so where we cannot able to give any drugs. Okay, so this is a other challenging thing we need to know. Another one important thing is C-spine stability. Okay, we don't know how the C-spine will be there in the trauma patient until otherwise ruled out. Always consider any trauma patient above the clavicle. Always consider there is a cervical spine injury unless otherwise proven. So in a conscious patient, recently we had a patient is fully conscious, but the patient is not able to maintain the airway saturation because the patient was having an anaphylaxis, had a bite by the wasp sting and present to us. He was able to open the eyes, obey whatever we say, but not able to speak out. The saturation is only 50%. So we need to intubate this patient, and not just giving an oxygenation is going to help it out. These are the various other things like sputum. This is when following the facial burns. A black sooty sputum can be there, or any neck hematomas. Okay. Recently, we had a patient who had a snake bite over the neck and developing a rapid swelling in the areolar alveolar regia. So thus trachea started compressing it. So the patient was having a labored breathing. So we have to intubate this patient. Or any facial injuries, or any patient who is having a trauma to the neck like a crepitus or a surgical emphysema, you should not directly intubate this patient unless we have an other backup. In a unconscious patient, okay, when we consider that the patient is unconscious, then the GCS, in the case of trauma, when the GCS is below 8, we have to intubate the patient. Whereas in a poison patients, or the patient who have been bitten by the snake or any other thing, where the GCS is less than 10, you have to intubate this patient. Snoring or any added noise from the nostril, it indicates that the patient is having a partial airway obstruction. Okay, abnormal chest and abnormal airway movement. Okay, abdominal and chest movement will always suggest that there is an airway obstruction is there. Okay. So we need to know always the patient is developing any fogging. Okay, you can see the fogging here, the fogging in the mask. Then it indicates that the patient is totally unconscious. We have seen a few times the patient will be put on a face mask, kept in the bed. Suddenly, when we see the patient will not having any breathing movement, but the patient will mask will show you some place. That means that the patient is not breathing properly, not breathing properly. Okay, so these are the various other conditions where it will make you difficult or obstruction towards the trachea. Okay, secretions or any tumors or any blood, esophageal, big esophageal foreign body. Recently, we had a patient with a big meat bolus enter into the esophagus and he was not able to pass it down. It got obstructed. So this is causing a compression over the airway, and the patient presented to us with a stridor. And after, with the help of our ENT colleague and gastro, we are able to remove that. Then we can able to save this, protect the airway. So how to do this? We need to have a certain basic airway management techniques, which is called as manual airway maneuvers. Okay, by doing a positioning the patient. Okay, we can able to do that. What are the manual airway maneuvers? Is a triple maneuver. We used to call it as triple maneuver. Triple maneuver is head tilt, and chin lift, or you can do a jaw thrust. If you suspect the patient is having a trauma, cervical spine injury, then always try to do a jaw thrust. Don't ever do the head tilt and chin lift. This may aggravate the spine injury. Okay, so even you want to document in your case report, medical legally valid, that you have to put the patient has been airway has been opened by the jaw thrust. Or we can, when the patient is obese, or you can even do a morning the sniff of air cushion, or the patient's head end can be elevated with a lot of pillows. I will show you. Or we can do a Heimlich's maneuver. If the patient is conscious, then we can do a Heimlich's maneuver or do a proper suctioning. Okay. So these are the various other technique by which we open it. I'm just showing you how to do a jaw thrust and as well as chin lift. Okay. When you're doing a jaw thrust, okay, this is the first picture, jaw thrust. It is just keep your index finger on the both side of the angle of mandible, and then you try to lift it up. Okay, you try to lift it up. It means the jaw thrust that will pull the tongue, preventing falling back. Okay, or we can do a chin lift if the patient is not having any cervical spine injury. Then you can see. You can see the cervical spine alignment here. It is in the neutral alignment when I am doing a jaw thrust. Whereas in doing a chin lift, it is going for a concavity of the spine. Okay. So this has to be noted. Patient positioning, it is always better to keep the patient in a sniffing position. Okay, sniffing position can be contraindicated if the patient is have been operated something for the cervical spine injury, plate fixation is done, then or ankylosing spondylosis is there, or severe patient. That can be easily identified by doing asking the patient to do a, if in case of elective, we can ask them to do a prayer sign. Okay, just ask the patient to keep like a namaste, where the patient's both fingers cannot touch each other. Then it means there is more chance of developing ankylosing spondylosis. So when the spine is misused, then they can go for even cardiac arrest when you are intubating. Okay. So this can be prevented in case of trauma, obese, and child patient. And in case of fixed deformity, like patient has been intubated, had been operated for some kind of cervical spine, where you can put the patient in a lateral position instead of supine, and you can try to intubate this patient. And this is a very important adjuvant, help you to suck out. Okay. And the important thing is you should not exit more than 15 seconds for the suctioning, because this will also suck out the oxygenation. So this will put the patient hypoxia, and at the same time, it will also prevent the positive end expiratory pressure level. So it can cause a collapse. So I have seen some patients who have been intubated. They will be putting for a 2 to 3 minutes. That indicates that there is loss of PEEP and it will go for a atelectasis. So now we'll ask few questions. Just we'll to ensure the class. Which of the following oxygen delivery methods provides the lowest fraction inspired oxygen? Nasal cannula, non-rebreathing mask, or a simple face mask or venturi? Excellent. Nasal cannula. So it is a low fraction of oxygen will be delivered. Clear? So which of the following above patients, the bag mask ventilation is contraindicated? Facial bone fracture, large laceration over the lips, endless elderly patient, or none of the above? Facial fracture. Yes, Ekta is correct. None of the above. There is no contraindication for bag mask ventilation. Only for the nasopharyngeal airway, the facial bone fracture is contraindicated. Large lip laceration are not going to cause here because we can do a reverse bag mask ventilation. It will cover the nostril. It will not come over the lip. So no need. Endless elderly patient is also not a contraindication, but it will be a difficult. Okay, it will be a difficult for you to do a bag and mask ventilation. None of the above is a correct answer. How many walls does the ambu have? 3, 5, 6, 4. 5, 6, 3. The correct answer is 3. Okay. So it is 2 walls will be there at the end connecting to the mask, and another one is at the reservoir end. So it is a 3. The first very step to aid the patient who is not breathing is clear the mouth, administer oxygen, apply a positive pressure, or open the airway. Answer is open the airway. Answer is open the airway. Good. So this is a case scenario. A 38-year-old man had a history of heavy alcohol. Okay, presenting to the emergency department with severe acutely intoxicated. Respiratory rate is 14 and saturation is 88% on the room air while sleeping and 98% when he is stimulated. Okay. The physical examination is notable for the patient who responds incoherently. He is in an alcohol intoxication, but the patient's gag reflex is preserved. Loud snoring is heard when he feel asleep. What do you need to do in this patient? Bag mask ventilation, endotracheal tube, nasopharyngeal airway, or oropharyngeal airway? What do you do? Endotracheal tube? No. Oropharyngeal airway? No. Endotracheal? No. Bag mask ventilation? No. Nasopharyngeal airway. Here, the patient is having an intact gag reflex. So no need to put a oropharyngeal airway. If you put a oropharyngeal airway here, this will induce vomiting. So further aspiration will happen. Bag and mask ventilation, patient will not allow you to do a bag and mask ventilation because patient is not unconscious. Patient is semi-conscious or conscious. Okay. Again, in endotracheal intubation is not needed. Only the left out is nasopharyngeal airway. This will prevent you falling back of your tongue. Clear? So, don't hesitate to give oxygen when it is indicated. Always give high flow oxygen when the patient is in distress. 100% oxygen has to be started in the cardiac as well as respiratory arrest for a few times. And then you have to titrate accordingly and taper the FiO2 as early as possible to prevent the atelectasis. And give 100% oxygen as pre-oxygenate before intubating the patient. In case of saturation, target for a normal patient is you keep 94. No need to keep the patient on 100%. I have seen many hospitals, the patient will be breathing normally. They will keep oxygen. Why? When you ask, they tell, sir, he is having saturation of 94, 95, only there. So no need. Okay, we have to give as a target is only 94%. Okay, in a COPD patient, we can maintain a target of 88%. When it is less than 88%, then we can give oxygen. Don't hesitate, but try to taper early and always look for the carbon dioxide retention. Okay, and oxygen does not mean ventilation. You have to remember this. Entirely different. Oxygenation is entirely different, and ventilation is entirely different. We are going to cover another session on ventilation, so I'm not coming here. Please remember, pattern airway is different from adequate ventilation or adequate breathing. Okay, entirely different. It should not be used as a misnomer. Okay, and now the question is how soon we should taper FiO2. As early as possible. The patient's general condition improves, saturation is maintaining, and you feel that there is no need for external oxygenation, we can stop it out. A few other questions I have. I'll try to answer that. How long for the obstructive atelectasis to occur? Actually, the literature says that after 48 hours, there are few reports are there, but majority of standard textbook says 72 hours. After 72 hours, when you are giving 100% of oxygen, there is always a chance for going for obstructive atelectasis can occur. Okay. And what is the maximum time to pre-oxygenate before intubation? I already told you 5 minutes. Okay. If the patient is not in a cardiac arrest and you are electively intubating the patient, give 5 minutes for the pre-oxygenation. If the patient is in a frank cardiac arrest or impending respiratory arrest, just give for 30 seconds to 40 seconds, then you can intubate. And if you are good in intubation and you don't take, you will intubate within a single attempt, then you can give a pre-oxygenation for 30 to 40 seconds or 30 to 60 seconds, not more than that. Any other questions? I'm happy to answer. What is the ideal position for intubation in a C-spine injury? Yes, manual inline stabilization has to be done. Okay, it can be done with a two person. One is in the single front and as well as in the back. But unless you are experienced in using it, don't allow the attender to be standing next to you. Ask the attender to stand opposite to you and have an inline manual stabilization. Then you can intubate. Specific indication for non-rebreather and partial rebreather. Non-rebreather, when you feel that the patient saturation is not improving, or if the flow of oxygen has to be given more, we can go for a non-rebreathing. When you are giving more than 10 liters, we can think. And you think that the patient, there is a chance that the patient can go for CO2 accumulation or a PCO2 narcosis, then you can use a partial rebreathing. But majority of the emergency room does not have a partial rebreathing. Okay, we can use only non-rebreathing, give for some time, and you feel that there is an increase in PCO2, then either you go for a non-invasive ventilation or ventilate the patient. Paralytic and sedative before intubation, again, it depends on your institutional protocol. In our center, and my chief never allowed us to intubate the patient after paralyzing. Okay, you can always sedate the patient adequately and then intubate. If you are confident that the patient, you can intubate and you can assess the airway previously, then you can paralyze and intubate. Or if you have other adjuvants like videoscopy or ENT surgeon or a surgeon is backup can create a surgical airway, then we can go ahead with the paralytic agent. That to use always a low short-acting paralytic agent like succinylcholine. Don't directly jump into atracurium or acronium. When NIV to be changed to invasive ventilation, if the patient is not improving your oxygenation, PCO2 buildup is more and the patient is unconscious or the patient is having a risk of aspiration, don't put a NIV, then you can go for intubate and ventilate the patient. How many liters of oxygen for COPD patient? Again, it is a tricky question. It depends. So ideally, we can start with 1 or 2 liters and maintain the saturation around 88%. Okay, the ceiling target is 88%. So if it is less than 88%, or the patient is in further deteriorating and other signs of hypoxemia is there, then you can go with the high oxygen. Don't bother about abolition of hypoxic drive. At as early as possible, try to taper it. Otherwise, convert this into an invasive ventilation. If there is no other questions, shall I finish, sir?
Yeah, Senthil, fantastic show. Yes, sir.
Fantastic. Thank
Yes,
you,
sir.
Dr. Senthil Kumaran. I'm thankful to Palaniappan who has introduced you to me, and I
Thank
have
you, sir.
chosen you for this class. Extraordinary lecture by you, and I think he will give some questions to me at the end of this session. We are going to take an exam, and
Yes,
those
sir.
questions will help me in taking for this exam.
Definitely, sir.
Dr.
Definitely.
Palaniappan, now give your comment, please.
Yes, sir. Really a fantastic show, Dr. Senthil Kumaran. He is holding the vice president post of the emergency medicine. Definitely, our complete physician postgraduate student will be definitely benefited because nowadays emergency medicine is a bread and butter. If you know emergency, he can earn something, and you should not. We are living in the litigation era, so how to handle the patient properly? Many times airway means you have to put suction. If there is any obstruction, you have to do that. After that only all the upper airway or lower airway obstruction, what to do, what not to do, everything you should know. And oxygen, the oxygen supply, especially COPD, keep SpO2 88% only. And any ICU patient, don't keep the SpO2 100%. Keep SpO2 more than 94% is more than enough. 100% O2 is necessary for the first 72 hours only. After that only, if you keep on pushing the oxygen, definitely it will land up in atelectasis. Lot of patients that's on the patients on the intubation, lot of atelectasis. Maybe it's a hospital induced actually. So atelectasis, common causes. So over-oxygenation, definitely it's contraindicated. Very safely you have to do. And suction is very, very important. It is very, very important. And always cervical spine injury, always rule out. Just rule out before doing all the things, all the maneuver, everything. And contraindication, relative contraindication, not absolute contraindication, everything, each and every word is very, very important. If you apply, definitely you will be a successful, complete physician in your practice. Because I did my 1 week, that's emergency medicine, CMC Vellore. Now I am running a 100-bedded hospital. Like me, many physicians should come up with complete physician care, running a 10-bedded ICU also as a complete physician. Okay, so you should be well versed with the teaching from my dear friend Dr. Senthil Kumaran. You will learn a lot. Acute emergency medicine only give money and fame also. You can save a lot of people. That will create a lot of fame in your area. Even you, if you are practicing in a rural area. I am practicing in a rural area in my native place. Just 3 months back only, my place became a taluk headquarters, running 100-bedded hospital. Like me, many physicians should come up by learning from my dear friend Dr. Kamlesh Tiwari sir, ICP Dean. You should learn a lot from this short certificate course. All the students should attend all 7 courses. You should be a complete physician rather than a compartmental physician. After completing your MD General Medicine or DPNB General Medicine, with these 7 courses, definitely you will become a master. You will flourish in your area. Thank you so much, Dean sir.
Thank you, sir. Thank you. Thank you very much to everyone, and good night.
Good night, sir. Senthil, good night, Senthil. Good night, sir. DP Singh, good night.
Excellent. This was excellent. I have joined from the very beginning. Really, you said the complete physician means emergency medicine, and not
Yeah,
only
yeah.
respiratory medicine. Yeah, very nicely, very nice and excellent. Oh, yeah. I really appreciate and congratulate Dr. This whole session.
Thank you, sir.
Thank
you.
you. Thank you.
Thank
very
you.
Good night, sir.
Good night.
Good
Good
night.
night. Thank you so much. Thank you.